Hello, I'm hematologist-oncologist Dr. Tony Talebi. Now we're going to discuss the management of stage 4 gastric cancer, cancer of the stomach. I have the pleasure of being with Dr. Ike Akinoli, Assistant Professor of Medicine at the University of Miami. Thank you for being here.
Thank you, Tony.
Okay, and let's assume now a patient presents to you with biopsy-proven cancer of the stomach, gastric adenocarcinoma, that has now unfortunately spread to other organs. What happens next for that patient?
Okay, when we have this situation with a newly diagnosed metastatic gastric cancer, then the first thing we do is usually to go back and talk to our pathology colleagues and make sure we're dealing with metastatic gastric cancer. In a lot of cases, we're dealing with metastatic gastric cancer, but I always think of something. Can I be dealing with something different that is curable? Is it a lymphoma or whatnot? Usually, it's very easy for the pathologist to distinguish between a lymphoma and a gastric adenocarcinoma. So yes, it's a gastric adenocarcinoma. Then I ask them the next important question. I ask them for the specific types of receptors that might be on the surface of the cancer cells that would help me plan their treatment. And in one situation, the specific type of receptor we usually ask for in gastric cancer is actually called HER2. And that has also been demonstrated in breast cancer. So we need to know the characteristics of the cancer cells before we plan the treatment adequately.
I see. So, is it possible to still cure gastric cancer that has now spread stage 4?
That question is something a lot of patients actually ask me, and is a question that I have to approach with honesty. At this time, gastric cancer that has spread is not considered curable. There's always a patient, however, that you can always refer to from anecdotal experience that will say, well, this guy had gastric cancer that had spread, and he actually lived for a very long time and died of something else. Now, if somebody has a spread, for instance, to only one organ that can be taken out, sometimes we take that out. That is usually not what we recommend anyway. So, yes, there might be the rare patient, but the truth is this: most of the patients with metastatic gastric cancer that has spread to other organs is not considered curable.
What is a Krukenberg tumor? Would you please explain that?
Okay, now Krukenberg is actually a physician, great physician, who found that when you have cancer of the stomach, for instance, it can go through the muscle of the stomach to the lining of the stomach, and when it gets to the lining called the peritoneal cavity, the cells actually do anything. They swim around, they float around, they drop down, and they can drop down to various organs. And one of the places where it can drop to in females is called the ovaries. So the tumors can actually go to the ovaries, and for some reason, this gastric cancer has the predilection to drop down to the ovaries and find fertile ground there and grow. So when it drops from the stomach to the ovaries and starts growing there, either in one or both ovaries, that's called a Krukenberg tumor.
I see. How does a patient's performance status or their age play into what this decision treatment you'll make?
Actually, the performance status plays a big role in our decision making. And what do we mean by performance status? When we see a patient, we usually look at the ability to carry out usual activities of daily living, like ability to take a shower, cook for themselves, stand for maybe 30 minutes, for instance, how up and doing they are. If you see a patient that is in bed all day long because of the disease, then those patients actually have an increased risk from chemotherapy and complications associated with chemotherapy. And if you have patients who are going to work and who are up and about most of the day, those patients are better able to tolerate chemotherapy. So the performance status is the most critical thing actually in our treatment decision. The age does not play so much of a role. The role of the age depends on the fact that the older you are actually, the more medical problems you might have, and the more medical problems you have, the worse your performance status is likely to be. So when we're looking at the performance status, first of all, we also look at it and say, is the performance status low because of some things that we can eliminate or take care of? So for instance, if a patient comes to me with a very bad performance status, he's unable to stand or walk about, and he's short of breath and everything, and he has gastric cancer that has spread, and I look at him and I see that he has severe anemia. For instance, his blood count is maybe hemoglobin of 5, just because he's been gradually losing blood from the stomach cancer. If I transfuse him and the performance status improves, that would not prevent him from getting treatment. So if we have a patient with a poor performance status, we try and fix the things that can be fixed, and if that leads to improvement in performance status, then we treat them.
I see. How do you address areas of pain in which the cancer has spread?
Pain. Now, thank you for this question. It's something that's actually very close to my mind. Most of my patients come to me and they say, look, doctor, I don't want to suffer. And that is usually a big concern of the patients. Now, there are different ways that we handle the pain related to cancer. Number one, we have the pain medication. So we have different types of pain medications, from Tylenol to other things like we call them the NSAIDs, which are related to aspirin, like ibuprofen, Aleve, naproxen, that we can use for cancer. We also have the opioid analgesics, which are stronger pain medication that we can use for cancer, like oxycodone, morphine, fentanyl, and codeine or Percocet. And we try to control your pain with as much pain medication as is necessary. When a patient has cancer and has pain due to cancer, we control the pain, and we use all the medications in our armamentarium to control the pain. Now, giving them pain medication is one thing. The next thing is tackling the cause of the cancer, tackling the cause of the pain. So if a patient has pain, we look at the pain and the location of the pain. For instance, if the pain is because the cancer has spread to the bone, and we know that if we send them to our radiation oncology colleagues for them to administer a short course of radiation to that area, that might help rapidly control the pain. Now, the other thing is, the pain is due to cancer, right? So if we start treating the cancer and the patients respond to the treatment, then the pain actually improves. So if we start them on treatment with chemotherapy and the cancer starts shrinking, then the pain starts going down, and some patients are able to completely go off pain medication. In fact, one of my patients recently, after the first round of chemotherapy, his pain essentially disappeared, and he's no longer on pain medication as we speak now.
That's great. Well, let's talk about the treatment. What chemotherapies would you favor in metastatic gastric cancer? In metastatic gastric cancer, actually, what we do is, depending on the performance status of the patient, the question is, should we be using combination chemotherapy or should we be using single agent chemotherapy? Some people feel it's still open for debate. I favor combination of chemotherapy drugs because I think the response rate is higher. Now, the question I ask is usually this: is the patient HER2 positive or not? If they have HER2 positive disease, then I use Herceptin, I use trastuzumab, or as part of the treatment. And when I use a trastuzumab-based regimen, we tend to use it in combination with chemotherapy. Now, trastuzumab is an antibody, basically. It's a monoclonal antibody that specifically targets these receptors that are the cancer cell surface and binds to them, and
and basically helps destroy these cancer cells, and is very effective in patients who have the positive disease. For the chemotherapy, we use combination of different drugs. We use fluorouracil, which is an anti-metabolite. Basically, it antagonizes the cancer cell's ability to use folic acid and leads to death. We also use the platinums like carboplatin, cisplatin, oxaliplatin. Usually for stomach cancer, we use any of these platinum drugs. We also have the anthracyclines, which is very loved by our European colleagues, and we also use it here. The common one used in stomach cancer is epirubicin, and we have the taxanes like docetaxel that can be used as well. Normally, when I'm treating patients with metastatic gastric cancer, I always think of side effects and quality of life. For instance, if I'm not treating them for cure, I always think of the combination of treatment that I can administer as an outpatient that is highly effective, so that the patients will have a good quality of life without needing to come into the hospital and be admitted every 3 weeks or 5 days or 1 week. I tend to favor the regimen that you can use as an outpatient, and I tend to favor a combination of drugs. The question is, do you do 2-drug combination or 3-drug combination? I think 2-drug combination is effective. I think 3-drug combination is effective. And basically, I've used a lot of 3-drug combination, but nowadays I'm tending more towards the 2-drug combination because I think it's equally effective and better tolerated by the patients.
Generally speaking, what are some side effects that a patient may experience with chemotherapy?
The side effects of chemotherapy are myriad. Most of the side effects we anticipate, and we actually try to prevent it from occurring. So when I have patients on chemotherapy, there are some things I usually go through side effects with them from head to toe. And I start from the head. I tell them, look, when you look at yourself in the mirror in a few weeks' time, you might look like me. That means you could have lost your hair. Now, they always find that funny and interesting, actually. But they try to reassure me that losing my hair is not too bad. Now, hair loss is something that can occur. So if you lose your hair, it's very worrisome for a lot of patients, and they can actually go through some psychological difficulties from hair loss. So we have things in place at like the wigs and other things that the patients have that they can use to still make them feel close to normal. Not all treatment combinations lead to hair loss. So depending on the patient's state of mind and everything, they might say, look, doctor, can you find a combination that will not cause as much hair loss as the other combination? So I present this one here, I present this one here, and they say, look, I don't really want to lose my hair. We have something that we can actually use. Now, we come down from there, and I say, okay, when you're on treatment with chemotherapy, part of the medications to prevent nausea, vomiting, and other side effects is actually steroids. And the patients with chronic use of steroid can develop cataracts. So that can lead to some visual blurring and visual impairment over time, especially for patients that have been treated over weeks to months and years. And then I come down to the mouth. I try to let them know about the side effects that can occur in the mucous membranes of the mouth and then down through the mouth to the esophagus, so they can have inflammation of the mouth, mucositis. That can cause difficulty eating, and that can cause more nausea, vomiting. With the mouth as well, I tell them about what usually occurs with chemotherapy, like your taste buds start behaving strangely, and sometimes food start tasting different, and sometimes food will start tasting metallic. And the patients, when they know that this can happen, they actually anticipate it. I try to let them know that their taste for food might change, and they might see that what they loved prior to getting treatment they no longer love, and they start developing new love actually. Sometimes the patient say, look, I'm now experimenting with different food, and they encourage that as well. Now, if I continue along the mouth through, I usually go down from the mouth and go to the stomach, and I try to talk about diarrhea. And that is something that can occur, in a significant number of patients with chemotherapy. And I usually encourage the patients about hydration and trying to stay adequately hydrated and have to take care of diarrhea with chemotherapy. I encourage my patients to have some Imodium or Lomotil at home that they can start on immediately they start having diarrhea. So that is, those are some of the effects. Then, if I've gone through the organs, then I come to the blood, which is usually where I try to dwell more because of some potential life-threatening complications, which I'm going to talk about now. The blood has different cells that make up components of the blood. Basically, you have the white cells, you have the red cells, you have the platelets. For the platelets, if your platelets go down with treatment, they can drop. Most of the time, because we monitor the patients regularly before each treatment, we detect drop in platelets, and then we tend to adjust the dose of chemotherapy based on how low the platelets are, and sometimes we postpone the treatment. Now, of course, if your platelets become so low, you can bleed, but it's very unusual for the patients to become so low that they bleed, because we tend to have adjusted the dose or have held the treatment. For the red cells, actually, if your red cells drop, you become anemic. So if you're anemic, you have increased fatigue, tiredness, or whatnot. You can have shortness of breath. Some patients would need transfusion just because of the severity of anemia. In the past, a lot of us used some agents to try and stimulate you to make more blood cells. But with the recent findings that these drugs can have their own problems, most of us have scaled back on the use of these drugs. We still use them to try and stimulate them and the body to make red cells, but we use them in a more controlled fashion nowadays. Now you have the white cells. If your white cells go down, that is actually something that is potentially life-threatening, because the white cells are they're part of the immune system, and they defend us against various infections. So if you have a very low white count, you are at increased risk of severe infection that can actually lead to death. So we monitor the white count, and we actually advise the patients in terms of how to go about if they have any problem like fever that's suggestive of infection. That is a medical emergency, and they need to be handled like one. They need to start antibiotics within the hour. Sometimes they need to be admitted rapidly, and we have set up places. All major cancer centers set up facilities for care of these patients just because of these complications. We just encourage the patients to be on the lookout for it. We don't want them to sit down at home when they start feeling bad. We want them to contact us immediately and be taken appropriate care of.
I see. As you know, many patients take their own herbal natural medicines. What are your thoughts about natural remedies in conjunction with chemotherapy?
Actually, for instance, I have some patients that come to me and say, Dr. Ike, I've been taking a lot of herbal remedies. In fact, some patients come to me and they've gone through different herbal remedies, and they are very concerned about going on chemotherapy because they want to be on natural products. And the first thing I try to ask them is this: do you know chemotherapy is actually a natural product? Because most of the chemotherapy drugs are gotten from we have some that's gotten from trees, like docetaxel, for instance, is gotten from the bark of a tree, of the yew tree. You have those that are gotten from various molds, for instance. So yes, we also deal with natural products. And some patients come with natural products, and sometimes I have issues with them, sometimes I don't. The first thing is this: if I know what you're taking, then I'm able to at least predict the interaction between what you're taking and what I'm giving you. In the absence of that, then I'm actually treading on unknown grounds, and sometimes that can be harmful to the patient. So I say the patient, for instance, if I have a patient on Zeloda, for instance, the patients on Zeloda have increased side effect when they are taking folic acid, which is a vitamin. So they have more side effects, and it can actually be it increases the toxicity of Zeloda just because the folic acid boosts the effect of Zeloda so much. And I tell the patients, do you know that being on the vitamin can actually be harmful when you're taking chemotherapy drugs? So I have no problems with them taking that. The only thing is that if I want you to know what you're taking so that I can plan and see if it's something that would interact with what I'm giving you. If not, then you can have increased risk of interaction between different natural products, including chemotherapy.
Very nice. I think most oncologists I've spoken to, what they want is full disclosure from the patient. Let us know what you're taking.
Yes.
Very nice. What are your recommendations in terms of exercise for patients?
Oh, that is one big place. I think the patients who are able to exercise actually maintain their quality of life a lot better than the patients who are unable to exercise and whatnot. And we've actually discovered that exercise, for instance, with exercise, modification of your diet and living a healthier lifestyle actually improves the quality of life a lot better. I think when you exercise, you release some of these endorphins and feel-good chemicals that actually makes the person feel good. So, for instance, even if you don't have cancer and you exercise, when you finish exercising, you feel very good, you feel excited, you feel on top of the world. Cancer patients feel the same way. Now, sometimes they might be limited in terms of the ability to exercise because of fatigue and whatnot. And what I normally encourage my patients to do is to, do it, but don't overdo it. If you were running a marathon every day and you can only run a half marathon every day, do the half marathon. If you were running a mile and you can only run 500 yards, do it. If you weren't doing anything at all, try and run 100 yards, if you can do it, and then try to push it and whatnot, because one, after the treatment for the cancer anyway, you still need to continue with good measures that would maintain your quality of life and whatnot. You need to give yourself some positive outlook in life, and that helps a lot with the exercise.
That's great. What if the patient has difficulty sleeping? How do you address that situation?
If my patient has difficulty sleeping, actually, the first thing I ask myself is, what is the impact of the diagnosis of cancer on the patient? Is there any component of depression to this? And most of the time, the first thing, I start with counseling. I start with trying to elicit any depression, because if I have a patient who is depressed and I'm able to handle the depression, then I'm actually able to impact their life better than actually giving them a prescription for sleeping medications. Once that has been addressed, I try to also encourage other measures like meditation, yoga, and other non-medical measures. Then I try to encourage the patients, if they need medication, to try some things like melatonin, and before I get to sleeping aids like Ambien and the benzodiazepines, which I try to avoid if possible, just because of the fact that they stimulate the liver enzymes, and when you stimulate the liver enzymes, you have potential interactions with the chemotherapy. And if I have somebody who has cancer that has spread to the liver, for instance, and they already have a marginal liver function, I don't really want to give them something that would put any added stress on their liver. So I find that those non-medication measures have helped a lot of my patients, much more than you can imagine.
Mm. What about sexual relations with a partner? What are your recommendations for that?
First of all, my patients not every patient who has metastatic gastric cancer is physically able to have sex anymore. Just because they might have gotten to the stage of their life where they are at the tail end. Now, not a lot of patients are still able to have sex, and sometimes there is guilt involved, like the patient's partner might be feeling guilty and thinking, oh, my partner is dying and I'm thinking of sex, but the patient still wants to feel normal and have that interaction, human interaction. So I encourage the patients who are able to have sex to actually continue with sexual relation. There might have to be some changes in terms of how it's done, just because of the limitations imposed by a disease condition. What I also encourage them to do is to make sure that they do not get pregnant or get their partner pregnant. For instance, because you're on chemotherapy, you can have damage to the cells, like the sperm cells or to the egg cells, and you do not want to deal with issues. So if you're a male, I encourage you to use preventive measures. Some patients have already had prior measures like a vasectomy, but if they've not, I encourage them to use something like condoms. If you're a female, we actually want you to also make sure that you're using preventive measures, just to make sure you do not get pregnant, because it imposes a lot of difficulty in terms of being able to care for the patient.
How do you actually know whether the treatment you're rendering is working? How do you check?
Oh, the first thing actually is that the patient tells me the treatment is working. So if I have a patient, for instance, who comes in to see me with stomach cancer and he has the cancer has spread to the liver, and he came to see me this week and he's having so much pain, and I started on treatment, and 4 weeks down the line the symptoms are all gone, and he was not previously unable to eat, and he's now eating very well and feeling very good. That tells me the treatment is working. Sometimes some patients have no symptom, but they have lots of disease, and they have some chemicals in their blood stream circulating that is produced by cancer cells, and I check the amount of that chemical. If it's coming down, it tells me that the treatment is working. Sometimes I have to wait until I repeat their scans in some months to actually know whether the treatment is working, but usually I know the treatment is working either by a combination of the patient's response, their blood counts, and also the imaging studies.
Have you ever encountered a situation where family members don't want you to discuss the prognosis or even the diagnosis with the patient itself? How do you handle that situation?
Tony, that's actually a very challenging question. First of all, as a physician, you have some ethical issues to deal with. Your duty is usually to the family, to the patient, and after the patient, you can now say you start having duties to the family members. Sometimes it's not that clear cut. For instance, if you have a patient who has dementia, and the caregivers are usually the family members, and the patient has cancer, and you cannot really have a reasonable discussion with the patient, you need to discuss with the family. And but if a patient has function and is able to discuss his disease condition and his illness and all whatnot, it's very difficult for the doctor and the family members. I think it's not really right for the doctor and the family members to come together and say we won't tell the patient what's happening. One, you're going to treat the patient. If you're going to treat the patient, you're going to treat him with some drugs, like chemotherapy drugs and all whatnot, that could potentially threaten his or her life, in addition to making him better. And he or she needs to know what he's getting. So I try to discuss this with the family members. I actually let them know that it's not very easy treating cancer without the patient knowing. If you're going to use the drugs you use and everything. And when you have that discussion and the family members realize most of the time the family members are trying to think of the patient's best interest, and when they realize that to actually go through the treatment for cancer, you need to know that you have cancer. They sometimes gradually break the news to the person, and then you can actually encourage them and also take it to the next level. But most patients who have cancer, even without anybody telling them, already know that they have cancer. Mm-hmm. So when you actually come to tell them and say, look, you have cancer, they're like, I knew that, I knew something was wrong, and I knew that the way everybody has been behaving, is something serious.
Yeah. Well, would you please explain what a clinical trial is, and would you recommend that for your patients with metastatic gastric cancer?
A clinical trial is actually the process of developing treatment for many medical conditions. In cancer, clinical trials play a great role. Now, we cure some patients with cancer, right? But you asked me a question earlier on about how many gastric cancer patients, how many metastatic gastric cancer patients are cured, and I told you that is not the usual story. So that means that where we are now is not perfect, and we need to move. And how do we move? Is by trying new stuff. So when we do clinical trials, basically we take information from the experience of our colleagues who've been in the lab with what we know right now in the clinic, and we try to come up with sensible design of studies that should improve the expectation and outcome of cancer patients and move it from where we are right now to something better. And I'll give you an example. As at 5 years ago, the use of trastuzumab or Herceptin was not common in gastric cancer. But due to clinical trials that have been performed, it's now something that we look for and actually use in gastric cancer patients regularly. And it's only through doing studies. And now, actually, the patients who survive the longest with gastric cancer are those that are treated. Metastatic gastric cancer, on the average, are those that are treated with a Herceptin-containing regimen. It has improved the life expectancy of those patients. So if you do clinical trials, you have the potential to give patients some new treatment that can actually be very good for cancer patients and actually move the goalpost or improve the outcome of cancer patients. The only thing about a trial is that you do not have a guarantee that that is going to be successful, right? But we usually try and enroll our patients in clinical trials. Now, for my gastric cancer patients, usually my default treatment option is a clinical trial. So if I have an open clinical trial that the patient will fit into, I encourage the patient to enroll in a clinical trial. Mm-hmm. Now, if I do not have an open clinical trial, or if we're in between trials, then I have the standard care that we offer to patients based on the experience from previous clinical trials, and I offer that to the patient.
I see. Would you please differentiate between palliative care and hospice care, and when would you recommend either for a patient with stage 4 gastric cancer?
Now, that actually is a very interesting question. Most people tend to mistake palliative care for hospice care. Mm-hmm. Palliative means to make better. So if you come to me, for instance, with gastric cancer and you're having pain from gastric cancer, as part of the treatment I'm offering you to palliate your symptoms would include pain medication, chemotherapy, it might include radiation therapy. All in all, my goal is to make you feel better and control your symptoms, and also to prolong your life. Now, hospice care itself is the concept of understanding that not every time would we be successful in treating someone. So if we look at a patient and we feel that the patient is at the tail end of his life, And then at that time we start thinking, is there anything we can even do better to make sure that this terminal aspect of life is controlled and the patient is supported, the family is supported much better, and that's where the hospice service comes into play. Hospice care can be done both at home and an inpatient facility. The concept of hospice basically means that you accept that the patient probably has less than 6 months to live and you enroll them in a hospice facility. And that helps somewhat. Now, if the patient is under the care of the hospice, if they have something like nausea or pain in the abdomen, they do not need to go to the emergency room. They call the hospice team, and the hospice team can actually send a nurse or sometimes a physician to the patient's home to take care of that symptom. And that means that they have enough time to spend with their family members. Now, some patients who receive hospice care in addition to chemotherapy or continuing treatment actually survive better than patients who get treatment without that hospice care. So we think that that support actually helps the patients a lot. For instance, in the lung cancer ward, that has caused a lot of excitement because we come to discover that hospice, that support that you offer the patient and family, actually it leads to better survival.
That's very true. How do you give your patients hope with stage 4 incurable disease?
Now, I discussed with my patient the goals of life at that time, and we have an honest discussion. One thing I don't do is I do not promise things like cure if I think it's no longer possible. What the patient wants to know at that time is, am I going to be in pain? Am I going to become totally and completely dependent on others? And that is where the hope comes into play. Now, most of my patients, I reassure them that for the pain, we can control it if you have pain. If you have nausea, we can control it. If you have symptoms, we can control it. And that is actually what gives them the hope. So I give them the hope about what we can do, and that is to improve their quality of life or to maintain the quality of life for as long as possible. At the same time as I'm giving them hope that we can maintain the quality of life, I ask them to make some plans in terms of eventual death. I ask the patient to be honest with the family members, to have things in place like a will, to have things in place like a power of attorney, to discuss with their family members in terms of end-of-life issues, cardiopulmonary resuscitation, CPR, intubation, ICU, where do I want to die, and all those things that are tough decisions. But patients who have this cancer, who are able to discuss this when they are with full facility, actually have discovered that the family members are able to cope much better with their death and with making decisions at the tail end of the patient's life than the patients who have not had this discussion. And I think by our having an honest discussion with the patient, it helps them a lot.
That's very well said. Thank you so much.
You're welcome.
Thank you for watching. We hope this has been educational for you as well.